Ugly. Play to record. We'll probably ask you to accept that. And we're going to share my screen. And then we do play from start, right? Okay, welcome to our very first Cancer Forum of 2024. As some of you might know, our clinic is a little bit new into integrative cancer therapy. There's some reasons for that I will get to here in just a moment. So we're going to go through some high points of our cancer program, the theory of cancer, our approach, and some possible treatments. And the reason I always say possible treatments is because everything is customized to you, the patient, what you're dealing with, and what may be good for one type is not good for another. We're also pulling protocols from all different places, different resources, some old data. So that's why it's so unique. So for those of you who don't know me, I am board certified in general surgery and critical care. So my training is very traditional surgery for oncology. I was looking at being a surgical oncologist. So I have a pretty good background in that. Did that for about 6 years before I went to 7 years of training and then 6 years of operating before I went to straight ICU and then now just integrative medicine. So lots of breast cancers, colon cancers, melanoma excisions, you name it, we did it. But now we're integrative specialists. We became famous for our treatment of COVID nationally. We're one of the national leaders on that. And COVID, as well as the COVID shots, actually that increase the risk of cancer and the aggressiveness of cancer. So we're now using those tools that we've perfected in a new arena. So here's a secret that's not really a secret. The same thing that can help you heal from cancer is the same thing that can help your athlete succeed, is the same thing that keeps you looking younger, is the same thing that slows aging, is the same thing that will give you more energy, right? These principles all go back to cellular metabolism. And so there's going to be a lot of common themes. It's just a matter of where are you on that slide? Do you need to go from sick to well, or are you well and trying to high perform? So this is one of my favorite sayings. This was from a book called by Deepak Chopra called Quantum Healing. And I paraphrased it here, but if you get a paper cut, you don't sit around worrying if you're going to heal your paper cut, right? We all just know that it's going to heal. There's going to be no trace of it, and we're all going to move on and be fine. This thing is, the body doesn't know the difference. The healing mechanisms that take care of a paper cut are the same things that heal cancer. The only difference is we just take for granted that we're going to heal from something small like a paper cut. And when we get a diagnosis, and I hate the word cancer, chronically fermenting cells is what we should be saying, abnormal cells. You're told that it's a terrible thing. So the stress of that knocks out the immune system. And then people are given these terrible prognoses, which puts your brain, your subconscious, into a pathway of, I'm really sick and here's what comes next, based on what you know about cancer and cancer patients. And probably the worst of them, right? We all imagine the worst case scenario first. I like to remind patients there's been a miraculous recovery from every cancer on earth, stage 4. So there's no reason that we can't do that with the right mindset, the right plan of action, the right roadmap, the right things at the right time. So theory of cancer, basically, this is a theory from, I believe it's the 1920s, that cancer is a metabolic disease. So what they look at is usually cells take in oxygen, they take in fat, they use thyroid to do that, to develop something called ATP, and this is called oxidative phosphorylation. This is how the cells make energy, and using oxygen and fat, our bodies make a lot of energy. There's an alternate metabolic pathway that these cells can shift into where they're just burning sugar. And when you just burn sugar, you don't make very much energy. I think you make 2 ATPs versus 38 ATPs. Think of those as batteries or little ticks on your cell phone battery. So you make much more energy if you use the normal oxygen process. But think about it. Cancer cells are chronically fermenting cells. They're shifting into sugar burning. They do this best in an anaerobic environment. So that's why our pro-oxygen therapies work so well, things like hyperbarics, is because we're putting that cell in an aerobic environment where it prefers a different metabolic pathway. So I don't want to get too much into this, but this is the difference. So oxidative phosphorylation, we're going to use The GLUT receptor glycolysis, we're going to generate pyruvate. We're going to use oxygen to make carbon dioxide, and this is going to make 38 ATPs. If you're in anaerobic metabolism where you don't have oxygen feeding the system, you only get 2. And in a cancer cell, you're in glycolysis. So you're just burning sugar. This is all you've got. And you're shunted out this pathway where you're making lactate and you only get 2 ATPs. So if you think of that, this is a metabolic process where cancer feeds sugar. That's really the root of this. That's how we treat it. So the approach that we're taking, number one, is a baseline evaluation, right? We have to know where we're starting and have measurable results and outcomes. So we have a lot of different assessments that we do. The next thing I need to know is, what do we need to heal from traditional therapies or from the tumor itself? You know, has a patient undergone chemo and radiation already and we have to undo some damage? You know, are they in the process of getting ready to go through surgery? Like, how can we best help them through and heal from those processes? The next thing is, and I tell people this all the time, your cancer team is looking at your cancer. They want to kill cancer. They're not looking at you. They're looking at your path reports and your images and your tumor markers and all of those things. And oh, by the way, you happen to be a patient who's sitting there and suffering. They often forget, they don't check your blood sugar. They tell you to eat what you want. They don't check your vitamin levels, which is critical to a lot of the therapies that they're prescribing to help them work. They tell people to eat whatever you want because your diet doesn't matter. I mean, if you have a cancer doctor saying that with the mountains and mountains of data that show that diet is critical, that is almost malpractice at this point in time. So we want to make your body as inhospitable to cancer as possible. We do that through diet, nutrition, things like that. Then we get into, these are kind of the tiers. Next, we're going to get into cancer-specific therapies, vitamin C, mistletoe, melatonin, things like that. There's a lot of repurposed drugs that I'm reading about right now, things like doxycycline and statins, fenofibrate. There's a lot of things that we can draw from the integrative world and the prescription world and potentially the chemotherapy world, right? If we can block the way the cells get sugar as many ways as possible, now we don't need as much chemotherapy to kill them. So the baseline assessment, what are we doing? One of the first things we're doing is called PNOE. This is a max VO2 testing that we are trying to get incorporated. Basically, if you've ever seen an Olympic athlete, like a story about an Olympic athlete, they have the big mask on and they're running on the treadmill. That is a max VO2 testing. The PNOE company has made that portable, so we can actually do that with somebody resting, sitting in a chair, or we can do that active, and we can see how much oxygen can your body burn. How efficient is your oxidative phosphorylation? Because my guess is it's going to be pretty low if cancer was allowed to develop in your body. The next thing we use are continuous glucose monitors. Again, if sugar feeds cancer, well, let's find out what your sugar levels are. So we know if you're spiking your blood sugar, are you nice and steady and stable? And if you're spiking your blood sugar, that's one of the first things that we want to work on. Next, a full panel of labs, either Quest or LabCorp. We also have cash labs for patients who are paying out of pocket that are much less expensive. I'm doing a lot of Genova stool testing. Let's look at the microbiome. Let's look if there's inflammation in the gut. Let's look how you're digesting and absorbing your foods. I don't want patients to start a high-fat diet if they can't absorb fat and they need digestive enzymes. And then, as applicable, urinary hormones for the hormone-positive cancers, mycotoxins and molds have a tie into this, as do heavy metals. So what are the symptoms that patients are commonly complaining about and healing from? One of them, the chemo-related things, can be fatigue. Neuropathy is a big one. Cachexia, right? They're losing weight and can't control that weight loss. So a lot of times, again, the doctors don't know what to do. So they say, eat whatever you want to because you need to put on weight. Well, that's just feeding the tumor, right? The tumor's robbing that sugar and you're not gaining weight or getting better. Related to surgery, wound healing, and then other specific complications based on what surgery it was. And then with radiation, we commonly see things like skin burns, colitis, and collateral damage in the nearby organs. So we have some strategies to mitigate that. So treatment. Food is the most important drug you consume at the highest dose. So what you're eating is either contributing to health or contributing to illness. There's no in between. Sugar, again, feeds cancer. That's a recurring theme we're going to talk about. So quitting sugar is going to be key. Now, whether you have a hormone positive cancer, where we talk more about a Mediterranean or pescatarian diet, or you're straight keto or somewhere in between, we can all agree that first step needs to be whole foods, organic as possible, as clean as possible, to promote healing. Again, most traditional doctors don't even talk about diet. I know specifically my own family was told your weight doesn't matter, your diet doesn't matter. This is a whole different issue. So that's important as well. We can also track ketones. There's a device called Keto Mojo. You can use that just like you do finger sticks, where you can track ketone levels, and there's some cancers that respond quite well to that. So again, getting into treatment of the diet, we have patients that call us, and you can imagine if you get a diagnosis of cancer and you're in the traditional system, you're the last priority, right? Patients are hearing, you can have an appointment in 2 weeks, 3 weeks, 4 weeks out. Oh, we need a prior auth this from your insurance. And patients are getting 1 or 2 phone calls a day, and they're left wondering, what can I do? What can I start doing to take care of myself as these other things are playing out? So we have created that first step list so patients can get started and advocate for themselves right away. So this can be a 3-step process, and it depends, right? Because each patient is a little different, how much progress they can make and in what time frame. So step 1 is reduce processed foods and sugars. So try to eat real whole foods. That's just kind of step 1. Step 2, there's a really good book I've talked to with most of my patients. I see some of you on here, Glucose Revolution. These are some great strategies to eat to not spike your blood sugar. So this is a really good next step to get to that next level of success. This is going to help reset insulin levels, because really the sugar is not as much the problem as the insulin helps the sugar get into the cells. So we're really looking at IGF-1 and insulin levels. And then again, step 3, depending on which tumor we're dealing with, is going to be high intensity ketogenic diets. And sometimes these are going to be pulsed, where they're 2 to 4 weeks at a time, and then we back off and take a breather and cycle that through. So vitamins. Vitamin C it's an interesting drug. I've been reading and hearing and researching it a lot. So vitamin C is an antioxidant at low levels, and there's a lot of misunderstanding about this within the cancer community. At high levels, at the IV doses, vitamin C is a pro-oxidant. So what it does is it comes into the cell and it turns into hydrogen peroxide and water, and that hydrogen peroxide creates reactive oxygen species that then kill the tumor. So you can imagine you actually need oxygen to do that. So vitamin C works very well in oxygenated environments. This is why we add things like hyperbarics. There's also an approach to do hyperthermia. So vitamin C infusion should be done 3 times weekly. The cancer cells hang on to that vitamin C for 48 hours at a time. So we're revamping how we do this, and so that we can do 3 times weekly vitamin C infusions for those patients with active cancer. We would, of course, downshift that to less frequent as we shift into more recovery phase. People are still coming in the chat, so that's why I'm going to let them in. Oh, here's another. Very good. So with the vitamin C infusions, we're going to be checking ascorbate levels before and after the infusion to make sure that we're hitting a therapeutic target. What they were finding is when they did just the vitamin C infusions alone, the patients would absorb all the vitamin C and they could never get the levels off the runway. They could never get them up where they needed to be. So they incorporated an oral vitamin C as well. We're doing 8 to 12 grams per day of vitamin C. We do the powder, and you drink it over the day. You get like a big bottle of water like this, and you drink it over a 12-hour period, because you can absorb a little bit of vitamin C all the time. This is really the only way to get those levels up so that we can then get therapeutic with the infusions. This is actually from a study I think it's Linus Pauling did. I can't remember the timing. I feel like it was in like 1970. They took a bunch of patients, I think 10 patients that were dying of pancreatic cancer, and they gave them 10 grams IV of vitamin C, and they gave them oral vitamin C. And everybody's like increased their survival time by 5 times. They repeated the study in Mayo Clinic in the 1980s, and they didn't give the IV version. They just gave oral vitamin C and showed no outcome difference. So the narrative became vitamin C doesn't work. but they weren't dosing it properly. And there's a huge difference between IV vitamin C and oral vitamin C. Vitamin D, we don't have a specific dose for vitamin D. Always it's targeted levels, and we want the levels to be 80 to 120. So a level of 100 doesn't intimidate me at all. I'm generally doing vitamin D 50,000 a day for a couple of weeks, and then we go to 10,000 a day with K2 if I don't have a starting level. If I have a starting level that says we're between 80 and 120, we'll just keep doing what you're doing. So that's why the dose is really dependent on the patient, how well they're absorbing that. And if we're doing oral and they're not absorbing it, we'll do the IM injections to get that going. Melatonin is going to be a mainstay of the treatment. We've recently added this. Melatonin, most of us are familiar with it for sleep. It actually doesn't put people to sleep. It regulates the circadian rhythm. And that's just one tiny thing that it does regarding cancer. So we're doing 150 milligrams twice a day. I'll go through the list. This is actually from a working group, How to Starve Cancer. So it helps with block angiogenesis, which is how tumors grow because they build new blood cells. Apoptosis, so that means killing of the cells. We want those cancer cells to die off and stop growing. Autophagy, this is the body cleaning up the cells. Endoplasmic reticulum stress, so this has to do with energy in the cancer cells. These are all the different mechanisms that melatonin has. So nutrient starvation, DNA methylation, regulation of survival signaling, suppression of metastasis. That's huge because most people die of their metastatic disease. They don't die of the primary. So if we can stop it from spreading, that's going to be a key takeaway. Let's see, regulation of epigenetic modifications. Epigenetics, we all have a set of genes. They're not all turned on. Our body decides which genes are turned on for which things. So there was actually an interesting study in prostate cancer patients where they had them eat a cup of broccoli a day. That seems like a pretty minor intervention. And they found that it upregulated, I think it was somewhere 40 to 80 tumor suppressor genes and suppressed oncogenes. So 1 cup of broccoli a day for a month or two had a pretty profound effect on how our body expresses its genetics. So this is an area, this is why all these things matter, because as we're feeding it better nutrition and getting rid of like detoxifying the body, it changes the way our genetics express themselves. Cancer stem cells, this is actually the Achilles heel of most traditional treatments. They target mature cancer cells. They don't target cancer stem cells, which are those baby cancer cells that can regrow once treatment is done. This is where people get in trouble. So melatonin, vitamin C, there's a bunch of things that block this. Ivermectin is known to block it as well. So that's an important strategy as we talk going forward. DNA damage response. Inflammation. So we want to upregulate the pro-inflammatory, the things we want. Inflammation will help us, and we want to downregulate the things that aren't. Changing the pH gradient. So this has to do with, again, the balance between inside the cell and outside the cell is really important. Immune regulation and tumor microenvironment. So there's a theory that our platelets surround our cancer cells and protect it from our immune system. That's why some of the treatments like aspirin, dipyridamole, NSAIDs, anti-inflammatories, ibuprofen, celecoxib gets rid of the platelets around the tumor and allows the tumor to be exposed to our immune system and the drugs that we have. Chemosensitizing. So a lot of the things we're going to talk about, the vitamin C and the melatonin, both help chemotherapy work better. Hyperbaric does the same thing because you need an oxygen-rich environment. Same with radiation. You need an oxygen-rich environment for the radiation to do its job. Radiosensitizing, we just talked about that. Prion proteins, microRNAs. So a number of different approaches, a number of different mechanisms is why we want to incorporate melatonin into this. So I'm going to leave it there. There's an entire list, and it really is beyond. This is kind of an introductory, just what are we doing and how are we doing it? Patients just want to get better, right? They don't care where they go to get better. if it's traditional, if it's integrative, if it's a little bit of both, people just want to get better. They want to live and they want to thrive. They don't want to be sick from cancer. They don't want to lose not be able to work, not be able to participate in life. 80% of patients want an integrative approach, and oncologists are among the least likely to entertain those treatments. So about half of doctors will kick you out of their office if you even bring these things up. Everything that we're using is backed by data. Some of it is mountains of data. Mistletoe has over 2,600 different studies. Vitamin C, very well studied, but these are not backed by big pharma because there's no big profit center with this. These are not patentable drugs. And an interesting thing, when I was reading How to Starve Cancer, when you look at the things recommended by the cancer societies, they tell people like diet doesn't matter, right? But on the back end, they're trying to figure out a drug that can make a diet more ketogenic. So they're literally giving you recommendations that actually the opposite of what they're trying to do pharmacologically. So that doesn't make a lot of sense either. One of the pushbacks when people explore integrative oncology, the problem is people get scared to death. They get told the C word. Their life flashes before their eyes, and somebody in their moment of terror says, let me usher you down the hall and put you on a roller coaster, and we'll take care of you. And they don't, people need to stop unless they have a true oncologic emergency. Most of them are not, right? There's a tiny percentage that are, and they need to be treated today. If it's not, we need to take a breath. And we need to look at our options. We need to realize there's an entire world of integrative oncology out there that we have to help people and not be rushed into treatments. When you have this, again, if someone told you had chronically fermenting cells, you'd be like, what are you talking about? You would not have that emotional response that we do to the word cancer. So that itself is part of one of our problems. Many people will come out of the woodwork and try to be helpful and have a lot of resistance to you doing things that are outside the box. One of them is if it was really helpful, the big cancer centers would be offering it. I can tell you when you work in a big medical system, the system keeps you in check. You don't get to go rogue. You do what everybody says you do. If you bring up new and creative ideas or alternate approaches or strategies, you are exiled. And so they don't really have a mechanism to bring in anything other than through a big pharma pathway. I thought it was really sad to read some patients will die because they want to be polite and not offend their doctors. That is true. That is true. That happened to my mom's best friend last year. I offered to treat her for free, and her doctors told her not to, and she died a horrible, painful death of metastatic lung cancer. And she was responding to our vitamin C infusions and things like that. So I've seen it happen. She was a very polite, very lovely, very compliant woman. We're not necessarily against traditional therapies. I mean, I've been recommending surgery, radiation, chemotherapy my entire career. I think it's changed a lot, and now we have immunotherapies that people don't know how to use and mitigate, that have a lot of, when you're presented with a lot of these cancer treatments, it's all good and no bad. Well, you have to do this. This is your next step. Or we had one patient that was said, do you want to be sick or do you want to die? Because those are your two options. He's not sick and he's not dying, and he's our patient and he's doing okay. So next steps. Basically, how we have set this up is if there's an integrative cancer patient, it's $14.90 for the original series of consults. That gets you, we try to do a very short order initial consult. You do an intake with one of our nurses. We get a plan of action for you right away. We get the labs cooking so that we can really get started with things. And then it's just $199 a month to continue, just like our concierge plan. So I think this is a really good value. Again, a lot of people are just so used to the insurance model. It's a new thing for them. It would be a monthly check-in, probably more often, especially if you're doing infusions with us. It would be a quarterly check-in with us. So we're going to be following NCCN guidelines with how to monitor patients and track them. And I'll get into that in just a second. Obviously, if you have any acute issues, you need have questions, complications, need a visit in between the quarterlies, that would be included as well. We're developing a couple of cancer stacks, one to get people started, because again, people want to know what can I do today? And we have those supplements. Those have been vetted and well-researched. And then we're creating 3-month stacks to basically, so patients can just every quarter, every 3 months, we're going to have a check-in visit, and every 3 months, we're going to have a plan of action. And then there will be iodine and DIM diindolylmethane for our hormone cancer stacks. We are part of the FLCCC study. This is an observational study. There is no treatment protocol. What they're doing is comparing traditional outcomes with non-traditional outcomes as a whole. They're looking at all the different treatments that we're offering. I think our clinic is one of the most aggressive, most integrative as far as doing the IV ozone, hyperbarics, everything that's there. There's a couple of things that we probably will be bringing online soon. The high-dose melatonin is one of them. As part of the study, we have volunteered to submit our data. So they're not paying for patients to be in the study. They're not paying us to do it. So patients do need to be just a normal concierge patient of our clinic. We do have a special consent form process to have their data included. And we expect long-term follow-up from those patients because we do want to provide really robust data to help support what they're trying to do. That is it in a nutshell. I'm going to stop sharing my screen now. I'm happy to take questions. You can drop them in the chat. I'll see what's here. You can raise your hand if you want to do that. Let's see. Do you worry about oxalates with vitamin C, especially MTHFR? Yeah, I've heard a lot about that. I believe Thomas Lodi has addressed this. He's never had a patient doing high-dose C, or he does a lot of green smoothies that have had kidney stones. So no. What do I mean by stacks? These are supplement groupings, a stack. So it's the different supplements that we recommend for each person. So we kind of group them all together so that it's easier to purchase and not have to figure out 4 or 5 different things. Can this be done alongside immunotherapy? Yes. So no matter what you're choosing to do, we work well with traditional. We have no problem with them. So yes, it can be done along immunotherapy. We want to make sure you're optimized, right? Your vitamin D level is good. That's critical for immunotherapy. We want to make sure you're 80 to 100 for that to work better. So everything we're going to do is going to help you feel better, be stronger, cells to work better, your therapies to work better. So yes. Can you comment on estrogen dominance and natural progesterone as part of preventive cancer treatment? I think we've been hacked. Yep, I think we've been hacked, guys. So if we can get Andrew out here. There we go. Remove. Okay. Let me go back to the question here. So estrogen dominance. So anytime we have estrogen dominance as part of a preventive plan, we would use something called DIM. We also make sure that the patients are stooling normally, because if you're constipated, you can reabsorb more estrogens. We're also checking something called beta-glucuronidase in the stool to make sure that's the case. I guess if you were on a preventive, I don't know what natural progesterone is. We use conjugated or micronized progesterone for part of our hormone therapy. I think it's been proven now that hormone therapy does not cause cancer. It can bring it to light because it can feed it, but no. Can all of this be done virtually, or is an in-person appointment needed? It depends where you're located. Obviously, our best success is for people who can come to our office and be part of our treatment, because my team is so lovely and wonderful and kind, and just being around that loving environment, I think, is very therapeutic for patients. In certain states, we can do it exclusive virtually. In some states, you do need to travel in first to see us in person first, and then we can do everything else virtually. So just call us and we can set that up. Thoughts for 5-year positive treatment plan for hormone positive breast cancer. Do you recommend having ovaries removed for pre and perimenopausal patients? For hormone positive breast cancer, I absolutely do not recommend having the ovaries removed. I actually don't recommend it for BRCA anymore either. I was on that train for a while where we were doing prophylactic mastectomies and prophylactic oophorectomies to get those out due to the high risk. I think if you're going to be on a preventive plan where you're doing DIM and an organic diet and optimizing your blood sugar and inflammation and all of those other things, that there's no need to have aggressive preventive surgery. Now, if there's something there and it's not preventive, that's a different story. Can this be done alongside second line FOLFOX? I would say yes. We can, anything we offer can be alongside traditional treatments. We would just want to look at what treatment that is and how we combine that. Stephanie, thank you. We are so glad we're open in North Carolina too. Today is the not the grand opening, it's the first soft opening of our Troy, North Carolina office. So Rhonda is there, and we're trying to spread out our footprint so that patients don't have to travel as far. Every office that we have is going to offer the MAH, the IV ozone, which I didn't talk about, which is also very critical to cancer. It's going to help your body improve energy production. It's going to help with detoxification. So we do that alongside of our IV vitamin C for cancer patients that want to pursue that. Yes, so Rhonda Wright is a nurse practitioner who's going to be leading that office. So she's phenomenal. We work together in the ICU. Every single person I've brought onto the team, I would trust to take care of my family. So you can trust them. And we also work very closely together. We're an extremely close-knit clinic and team. We're constantly talking about patients. How can we better serve? How can we help in advancing this? So you can be confident. I'm building the treatment roadmaps, but they're individualizing it with our oversight for each patient. All right, I appreciate all of you being here today. Thank you so much. If you know somebody who's suffering from this, and they're interested in exploring this, we'd love to help them. I'm just like we got really good at treating COVID patients, we are going to be really good at treating cancer patients, giving them hope, giving them things that are not going to make them sick. It is a huge, thank you, Jane. It is a huge time. It is a huge monetary investment. It is a huge effort that we're undertaking, and I have not done it until now because it is such a big thing, and with my traditional background, I wanted to be very responsible with how we make these recommendations. My perspective on breast mammogram versus ultrasound. Ideally, it would be lovely if we could screen with ultrasound. Most places won't do that. What I tell patients, I mean, I'm used to working off of a mammogram. I tell patients you can do an ultrasound, we can do thermography, and if we find something, we're going to revert back to mammogram to put you down the pathway to get it worked up. So we can start down other pathways, but eventually we're probably going to end up on that pathway. So very good. Well, thank you all. And again, I appreciate you sharing this with people. We do have a YouTube channel it's called James Clinic. So you can subscribe to that. We'll post things like this there. This is how we get the word out, is just individual, one at a time. So thank you all. Have a blessed day. We appreciate you.